Hello viewers, welcome to Bachelor course of Population Studies. In the last lecture, we discussed about the National Family Health Surveys. Today, we will discuss National Rural Health Mission, Framework for Implementation and the tasks ahead. Health is an important determinant of human efficiency. The World Bank in its study has indicated that about 50% of the differences in growth rate of developed and developing economies can be attributed to ill health and low life expectancy. No country has ever entered the high growth strategy without significant improvements in health status of its citizens. There is a circular relationship between health and growth of the economy through a number of interrelated factors. Economic growth brings better health status and higher health outcomes, lead to more productive labor force, which positively influences the level of national income. For individuals, healthy life is one of the most important goals of life. Health is wealth is an old adage. Thus, there is no doubt that maintaining our physical and mental abilities is an essential part of human welfare. In most of the developing economies, the availability of health facilities suffers not only the problem of adequacy but also that of accessibility, affordability and the quality of services. The expenditure by government in the health sector assumes greater importance in these economies, as majority of the population is either poor or vulnerable, especially in rural areas where majority of the population lives. There is also a need to coordinate various health programs whose goals can be achieved only if they are followed in consonance with each other. Keeping these things in mind, the Government of India launched National Rural Health Mission or NRHM on 12th of April 2005. The mission adopted a synergistic approach by relating health to nutrition, hygiene and safe drinking water. It also aimed at reducing the personal as well as regional inequalities regarding access to good quality health services across the nation. Now it is important to discuss the vision, goals and the strategies of National Rural Health Mission. While the NRHM was launched, the public expenditure on health had declined as percentage of GDP from 1.3% in 1990 to 0.9% in 1999. There was a lack of synergy among numerous health programs along with near absence of effective community participation. Further, it was also found that more than 90% of the Indians were not covered by any health insurance, and under conditions of hospitalization, an average citizen spends about 58% of its total annual household expenditure. Such conditions generally push them below the poverty line or under the debt trap. In this perspective, the National Rural Health Mission or NRHM vision envisaged provision of effective health care to rural population throughout the country. To begin with, a special focus on 18 states in 2005. These states had weak public health indicators and weak infrastructure. Now we can discuss about the main goals of NRHM. These are: the first and foremost objective of the NRHM was to reduce the infant mortality rate and the maternal mortality ratio. Number 2, the NRHM aims to provide universal access to public health services such as women's health, child health, water, sanitation, hygiene, immunization and nutrition. Thirdly, it aimed to prevent and control communicable and non-communicable diseases, including locally endemic diseases. It was targeted that malaria mortality will be reduced by 50% by 2010 and another 10% by 2012. The mortality due to Kala Azar will be reduced by 100% by 2010. The deaths due to filaria, microfilaria to be reduced by 70% by the year 2010, 80% by 2012 and total elimination by 2012. Mortality due to dengue to be reduced by 50% by 2010, and regarding the tuberculosis, the mission aimed for early detection and maintain the cure rate at 85%. Number 4, access to integrated comprehensive primary health care. Number 5, for population stabilization, gender and demographic balance, the total fertility rate was aimed to reduce to 2.1 by 2012. Number 6, revitalize local health traditions and mainstream Ayush, that is Ayurvedic, Yoga and Naturopathy, Unani, Siddha and Homeopathy. Number 7, promotion of healthy lifestyles. Now we can discuss about the strategies of NRHM. The strategies of NRHM can be broadly divided into two broad categories of core strategies and the supplementary strategies. Now we can discuss these strategies. Number 1, the core strategies. The core strategies include to train and enhance the capacity of Panchayati Raj institutions to own, control and manage public health services. Promote access to improved health care at household level through accredited social health activities or ASHA. Health plan for each village through village health committee of the Panchayat. Strengthening sub-center through an untied fund to enable local planning and action and more multipurpose workers or the MPWs. Strengthening existing primary health centers or PHCs and the community health centers or CHCs, and provision of 30 to 50 bedded CHC per lakh population for improved curative care to a normative standard, that is Indian Public Health Standards, defining the personnel, equipment and the management standards. The next one is preparation and implementation of intersectoral district health plan prepared by the district health mission, including drinking water, sanitation and hygiene and nutrition. Integrating vertical health and family welfare programs at national, state, block and district levels. Providing technical support to national, state and district health missions for public health management. Strengthening capacities for data collection, assessment and review for evidence-based planning, monitoring and supervision. Formulation of transparent policies for development and career development of human resources for health. Developing capacities for preventive health care at all levels for promoting healthy lifestyles, reduction in consumption of tobacco and alcohol, etc. Promoting non-profit sector, particularly in underserved areas. Now we can also discuss about the supplementary strategies. These include regulation of private sector, including the informal rural practitioners to ensure availability of quality services to citizens at reasonable cost. Promotion of public-private partnership for achieving public health goals. Mainstreaming Ayush for revitalizing local health traditions. Reorienting medical education to support rural health issues, including regulation of medical care and medical ethics. Effective and viable risk pooling and social health ensured to provide health security to the poor by ensuring accessible, affordable, accountable and good quality hospital care. Now let us discuss about the plan of action. In order to fulfill its objectives, the NRHM has framed a plan of action so that all the main components of this mission work in a coordinated manner towards the common goal of improvement in health status of the rural population. Main components of this plan of action now can be discussed. Number one, the first important component of this plan of action is accredited social health activist, that is ASHA. ASHA is very important component of the plan of action of NRHM. It is an agent through which all the facilities can reach the common masses. Therefore, every village or a large habitat is supposed to have a female accredited social health activist or ASHA chosen by and accountable to the panchayat. She will act as the interface between the community and the public health system. ASHA is an honorary volunteer receiving performance-based compensation for promoting universal immunization, referral and escort services for reproductive and child health program, that is RCH, construction of household toilets and other healthcare delivery programs. She is also responsible for preparing and implementing the village health plan along with Anganwadi workers, ANMs, functionaries of other departments and self-help group members under the leadership of Village Health Committee of the Panchayat. She is provided with a drug kit containing generic Ayush and allopathic formulations for common ailments. For upgrading the knowledge of the ASHA, on-job training of 23 days is provided, which is spread over 12 months. The second plan of action is that of strengthening the sub-centers. At the time of inception of the NRHM, it was felt that in rural areas, the health facilities are inadequate, not only due to lack of funds, but also due to lack of supplies of medicines and other related equipments, staff and the buildings. Therefore, it was realized that all these deficits should be plugged simultaneously. In order to fill the deficit of required staff, the required number of ANMs was proposed to be appointed along with the multi-purpose workers, that is the MPWs. It was decided that the ANM would be a resident of the village falling under the jurisdiction of the sub-center and should not be transferred before completing 10 years at the same sub-center. As far as the construction of buildings is concerned, it was planned that the new buildings would be of an area of around 500 square feet and in addition would have staff quarters for the ANMs. The state would also be supported in their efforts to renovate the existing buildings. The center would contribute 75% of the total fund requirements for the construction of the sub-centers in a phased manner over the mission period. Besides the usual recurring cost support to the sub-centers are given an untied support of Rs 10,000 per annum. Adequate provision of medicines is made not only pertaining to reproductive and child health program but also of other communicable diseases. These essential drugs include both allopathic and Ayush medicines. The third plan of action is strengthening the primary health centers or the PHCs. At the PHC level, the mission aims to cover all the deficits of manpower, buildings and essential supplies of medicines and the related services. The PHCs were expected to provide 24-hour services along with nursing care by increasing the number of staff nurses and lady health visitors. The PHCs are supposed to have both basic emergency, obstetric care and sick neonatal and child care skills. Within the Panchayati Raj framework, there is a proposal to constitute a Hospital Development Committee or HDC or a Rogi Kalyan Samiti or RKS at the PHC level to review the utilization of funds, recruitment of staff and frame overall health plan within the broad framework for public health standards. Besides providing services relating to RTI, STI, that is reproductive tract infection or sexually transmitted infection, the PHCs would also facilitate counseling, lab testing for HIV, AIDS, protecting the confidentiality of the patients. The next plan of action is strengthening community health centers or the CHCs for first referral care. Under the mission, the CHCs are conceived as the first major curative health service providers addressing 80% of all ailments requiring outpatient services or hospitalization with all facilities for emergency obstetric care. Of course, PHCs would handle all services that an MBBS doctor is qualified to provide without the specialist support. A key strategy of the mission is to operationalize existing CHCs according to new Indian public health standards, and accordingly the services, recruitment of health staff and infrastructure is proposed to be improved. The functioning of the CHCs will be managed by Rogi Kalyan Samitis and the Panchayati Raj institutions. The next plan of action includes district health plan. The district health plan reflects the convergence with wider determinants of health like drinking water, sanitation, women's empowerment, child development, adolescents, school education, female literacy, etc., which are consolidation of the village health plans. District health plans provide overall planning framework and financial parameters along with arranging training inputs for the block and village planning teams. District become core unit of the planning, budgeting and implementation. Centrally sponsored schemes could be rationalized, modified accordingly in consultation with the states. All vertical health and family welfare programs at district, and state level merge into one common district health mission at the district level and the state health mission at the state level. Another plan of action is public-private partnership for public health goals. Since almost 75% of the health services are provided by the private sector, the NRHM visualized that the private sector should be duly involved in achieving the public health goals through regulation. The need is felt to develop the guidelines for public-private partnership or PPP in health sector, identifying the areas of partnership which are need-based, thematic and geographic. In this partnership, the lead role is to be played by the public sector. Another important plan of action is health financing. A task group was set to examine new health financing mechanisms. A desirable health financing edifice is one which not only reduces the out-of-pocket expenditure on healthcare but also lessens the probability of any financial impoverishment while meeting healthcare needs. Accordingly, the Government of India has been mobilizing resources for distributing across different entities, intervention and activities in the health system. All the wage components and the recurring cost of the CHCs are to be reimbursed. Adequate technical, managerial and accounting support is to be provided in managing risk pooling and health security. Where credible community-based health insurance schemes exist or are launched, they will be encouraged as part of the mission, and IRDA will be approached to promote such CBHIs, which will be periodically evaluated for effective delivery. The central government will provide subsidies to cover a part of the premiums for the poor and monitor the schemes. The next plan of action is related with reorientation of health and medical education. The NRHM felt the need of reorienting medical education to support rural health issues, including regulation of medical care and medical ethics. It proposes to work with the departments of education to make health promotion and preventive health an integral part of general education. Apart from promoting new colleges and increasing the number of seats in existing colleges, the need is also felt for universal continuing medical education programs which are flexible and ensure that they keep abreast of medical advances, refresh and continuously upgrade existing knowledge and skills. Now let us discuss about the institutional mechanism, technical support and the funding of NRHM. For the universal access to improved health facilities, the NRHM has visualized a federal structure of the institutional mechanism. It seeks to empower the PRIs at village, block and district levels. Following this institutional structure, the Village Health and Sanitation Committee, that is VHSC, is formed in each village within the overall framework of Gram Sabha, in which proportionate representation from all the hamlets is ensured and adequate representation to the disadvantaged categories is given. At the next level, the sub-health center is accountable to the Gram Panchayat and shall have a local committee for its management with adequate representation of VHSCs. At the PHC level, all the Gram Panchayats of the villages covered by the PHC should be suitably represented in its management. Then the block level PHC and CHC have involvement of Panchayati Raj elected leaders in the management, even though Rogi Kalyan Samitis are also there for day-to-day management of the affairs of the hospital. At the district level, the Zilla Parishad is directly responsible for the budgets of the health sector and for planning for people's health needs. Public health management at the district level devolve to the District Health Society, which is under the effective leadership and control of the district panchayat, the participation of the block panchayats. Concerted effort with the involvement of the NGOs and other resource institutions are also being made. A system of periodic Jan Sunwai or Jan Samvad at various levels is also proposed to empower community members to engage in giving direct feedback and suggestions for improvement in public health services. Under the NRHM, the budget outlay on health was proposed to be increased by 30% every year. States are proposed to increase budget allocations by 10% annually to support NRHM activities. Of the total outlay on NRHM, 10% is committed to the 8 northeastern states, which are critical for achieving the objectives of NRHM. Under NRHM, a maximum of 10% of funds are to be spent at the state level, 20% at the district level, and at least 70% at the block level and below, so that maximum benefits of affordable and quality health care reaches the people at the grassroots level. As per the 12th 5-year plan, for achieving all the targets under NRHM, total health expenditure should not be less than 2.5% of GDP or approximately 3 lakh crores over the plan period. Under the 12th plan, the current pattern for determination of resource envelope of the states under NRHM will be continued. The states should allocate higher resources to the high focus districts to bridge the gap between the high focus and the non-focus districts. So students, let us conclude the present lecture. To conclude, we can say that the National Rural Health Mission was conceptualized in response to what were perceived as systematic flaws in the health system, namely the lack of a holistic approach, absence of linkages with collateral health determinants, gross shortage of infrastructure and human resources, lack of community ownership and accountability, non-integration of vertical disease control programs, inadequately responsiveness to community needs, and lack of financial resources. Regarding the management of resources and the tasks, the framework of Panchayati Raj institutions has been strictly followed so that the degree of community participation can be raised and the health facilities can reach to the common masses to the fullest possible extent with due emphasis on improvement of the quality of health services. Though the NRHM has shown a significant progress on a number of targets, but things are not yet satisfactory. The regional differences are still there. The achievements in the focus states are still far from the targets. Therefore, the failures at the implementation level need utmost attention. Until these failures are not addressed, any policy aiming at improving the health status of the poor masses in rural areas will not bring the desired results. And the idea of building a healthy nation will remain an unfulfilled dream. That's all with today's lecture. I hope you must have enjoyed it.